NIPAH virus. It is a communicable disease, viral disease. Look at this picture, shows that NIPAH outbreak and virus. Look at this detail going on. Introduction. NIPAH virus is a zoonotic virus, meaning it is transmitted from animal to humans. It can also spread through contaminated food or directly between people. First identified in 1999 during an outbreak among pig farmers in Malaysia. The NIPAH virus has been recognized as a severe threat due to its high fatality rate and the potential for epidemic spread. Definition. NIPAH virus belong to the Paramyxoviridae family. Genus NIPAH virus. It causes acute respiratory illness and severe encephalitis in humans, often leading to death. Types. NIPAH virus does not have multiple types or strains. However, variants in the symptoms, severity, and mortality rates have been observed across different outbreaks, possibly due to minor genetic mutations or host factors. Causes. The primary cause of NIPAH virus infection is direct contact with 1. Fruit bats, natural host of the virus. 2. Contaminated fruits, date plant sap contaminated by bat saliva or urine. 3. Infected animals, especially pigs. 4. Infected humans through close contact, body fluids, or respiratory secretions. Transmission. NIPAH virus can spread through 1. Animal to human transmission, primarily through contact with infected bats or animals like pigs. 2. Human to human transmission through contact with infected bodily fluids or respiratory droplets. 3. Foodborne transmission, injection of fruits or raw date palm sap contaminated by bat secretions. Risk factors. 1. Occupational exposure. Farmers, animal handlers, and health workers are at high risk. 2. Consumption of contaminated food, raw date palm sap or fruits contaminated by bat. 3. Geographical location. Outbreaks have mainly occurred in South Asia, particularly Bangladesh and India. For close contact with infected individuals, this is especially risky for healthcare workers and family members. Complications: 1. Encephalitis, inflammation of the brain leading to severe neurological symptoms. 2. Respiratory distress, severe respiratory symptoms including acute respiratory distress syndrome ARDS. 3. Seizures and coma often precede death in severe cases. 4. Persistent neurological issues. Survivors may suffer long-term cognitive and psychological impairment. 5. Death. Case fatality rate range from 40% and 75% depending on the outbreak. Pathophysiology. NIPAH virus enters the body through respiratory or oral routes and targets the endothelium, causing vascular inflammation and leakage. The virus spreads rapidly through the bloodstream, reaching the central nervous system, where it causes encephalitis. It also affects respiratory organs, leading to severe respiratory distress. Pathophysiology of NIPAH virus, step-by-step process. 1. Viral entry, initial contact, primary sites of entry, to attachment and entry into host cells. Cellular receptors, membrane fusion. Three, replication and transcription, RNA release, protein synthesis, assembly. For cell-to-cell spread, budding and direct spread. 5. Vascular damage and systemic spread, endothelial infection, increased permeability, dissemination. 6. Central nervous system, CNS, inversion, blood-brain barrier, encephalitis, viral replication in neurons. 7th step, respiratory system involvement, lung involvement, pneumonia cause. 8. Immunoresponse, cytokine storm, delayed immunocontrol. 9. Organ damage and complications, multiple organ failures, severe neurological sequel. 10th outcome, death or survival. This step-by-step process outlines how NIPAH virus invades the body, replicates and leads to severe systemic and neurological complications. Signs and symptoms. The incubation period ranges from 4 to 14 days. Symptoms include: 1. Early symptoms: fever, headache, muscle pain, sore throat, nausea and vomiting. 2. Advanced symptoms: dizziness, altered consciousness, severe respiratory symptoms, seizures, encephalitis and coma. Diagnosis: 1. History and epidemiology. Suspicion arises in individuals with relevant exposure histories in epidemic areas. 2. Laboratory test. A. RT-PCR, detection of viral RNA in body fluids, blood, urine, cerebrospinal fluid, CSF. B. ELISA, serological test to detect antibodies, IgM and IgG. C. Virus isolation, rarely used but provide definitive diagnosis. D. Immunohistochemistry, post-mortem diagnosis in some cases. Nursing diagnosis. 1. Risk for infection related to exposure to NIPAH virus. 2. Impaired gas exchange related to respiratory symptoms. 3. Risk for ineffective cerebral tissue perfusion related to encephalitis. 4. Acute confusion related to CNS involvement. 5. Imbalanced nutrition related to nausea and vomiting. Disease management. 1. Supportive care. This is the mainstay of treatment. Hydration and electrolyte balance, mechanical ventilation for severe respiratory symptoms, and anticonvulsants for seizures. Three, intensive monitoring, especially for neurological symptoms and respiratory status. 4. Isolation to prevent human to human transmission. 5. Psychological support for both patients and family members. Treatment. No specific antiviral therapy is currently available. 1. Ribavirin has been used with limited successes. 2. Monoclonal antibodies, experimental treatments. 3. Intensive supportive care. This is crucial to manage complications like encephalitis and ARDS. Psychosocial medicine. 1. Emotional support for both patients and their families, as the disease has a high fatality rate and can cause considerable distress. 2. Counseling for survivors experiencing neurological sequel. 3. Community education in endemic areas to reduce fear and promote preventive measures. Prevention. 1. Avoid contact with sick pigs or bats, particularly in area with known outbreaks. 2. Avoid consuming raw date, palm shape or fruits contaminated by bats. 3. Practice good hygiene, wash hands frequently and avoid close contact with infected individuals. 4. Personal protective equipment for healthcare workers caring for NIPAH patients. 5. Surveillance and containments, early detection of cases and strict quarantine measures during outbreaks. In conclusion, NIPAH virus remains a significant public health concern due to its high mortality rate and the absence of specific antiviral treatments. Early detection, isolation, and supportive care are critical in managing outbreaks. Preventive measures focusing on minimizing human-bat interactions and ensuring safe food consumption can help reduce the risk of future outbreaks. Public health education and international collaboration are essential to mitigate the global threat posed by NIPAH virus. Thank you. Have a nice day.